Hello again. In this lecture, we are going to cover two issues. First, the approach to nausea, and then we are going to talk about irritable bowel syndrome. I'm sorry again that these slides are in Turkish, but I am going to talk in English. When we are approaching nausea, that is one of the most common symptoms in gastrointestinal patients. We take into account the age and gender of the patient. And we ask for cigarette smoking, alcohol, or some addicted drugs, because in their service, alcohol intake and addicted drugs may be the cause of nausea. And I am going to say this symptom is much more common in cigarette smokers. And we also assess the duration of symptoms. If it has been present for a very long time, then probably the cause is benign. And the relationship between fasting state and satiety, because in hyperacidity and related diseases like duodenal ulcer, nausea is much more common in fasting state. But if it is present in satiety, it means that it may be due to gastritis or some type of space invading process in stomach, like malignancy or any type of tumor invading stomach from the outside. What is the relation with psychological stress? Because in any type of acute stress, the subject will feel some nausea. Is there a awakening from sleep with nausea? So an organic etiology is more likely. Is there any change in the bowel movements? And is there any change with smelling and tasting? So if these are present, the origin of nausea may be a central one. There may be something wrong with brain. And is there a relation to menstrual periods? Because in this case, it may be due to premenstrual stress. Are there comorbidities? Because nausea is more common in the patients with chronic renal failure, chronic obstructive lung disease, and heart failure. Vomiting is a much more important symptom than nausea, so it should be assessed very seriously. First of all, we should decide whether this is a real vomiting or regurgitation. Regurgitation means that the food content is coming from esophagus. It may occur in, for example, achalasia or tumors in esophagus obstructing the esophagus. And you remember the rumination, which is a psychological disturbance. The patient, after ingesting the food from stomach, the food returns to stomach again and chewed and again swallowed. So that's something physiologic in cows, but not in humans. Whether the vomiting is happening after a nausea, that is what's happening in most of the time. But if vomiting is happening without any nausea, it may mean that there is maybe a tumor in brain, or there may be some pressure into cisterna, so hydrocephalus may be present. And if the patient is trying to relieve from the nausea with provoking vomiting by himself, then it may be due to pyloric stenosis or gastroparesis. Gastroparesis is a disease characterized by poor movements, muscular movements of stomach. It may happen idiopathically, but mostly this is the result of neuropathy of type 2 diabetes. If we assess the reasons for acute reasons for nausea and vomiting, It may be gastroenteritis, acute gastritis due to Helicobacter pylori or drugs, NSAIDs, non-steroid anti-inflammatory drugs, aspirin, and some antibiotics may produce acute gastritis, especially if the nausea is present in fasting state, maybe due to that duodenal ulcer. But if it is happening in satiety, it may be due to gastric ulcer. Acute hepatitis is another reason for nausea, and we call nausea here as a prodromal symptom. So in the beginning, the only symptom may be nausea, but after that, jaundice develops. It is present in acute cholecystitis, the gallbladder inflammation due to stones, in acute pancreatitis, appendicitis, and in the acute presentation of Crohn's disease may also cause nausea. And it is present also in bowel obstructions. So you see that there are myriad of causes of nausea. It is also a symptom of peritoneal irritation, and it may happen in familial Mediterranean fever, a special type of peritonitis, porphyria, and abnormality in porphyrin metabolism. It is present in diabetic ketoacidosis, and it may be a symptom of adrenal failure, which is called as Addison's disease. What are the chronic conditions leading to nausea? Reflux disease, chronic Helicobacter pylori gastritis, atrophic gastritis, gastric tumors, chronic cholecystitis, chronic pancreatitis, chronic liver disease, chronic renal failure, and renal infection may also cause nausea. In physical examination, we pay attention whether ascites is present, so it is something suggesting peritonitis. The sensitivity in Murphy point, which is a sign of cholecystitis, presence of hepatomegaly and splenomegaly, which points towards liver disease, McBurney sensitivity, which is a symptom of appendicitis. Tenderness and rebound tenderness are the symptoms or are the signs of peritonitis. If dehydration is present, it may point to diabetic ketoacidosis. Presence of clepotage. Clepotage means that when you put your hand in stomach in the sting position, epigastrium, and you push it, there will be a churning sensation. That is clepotage. And if there is decrease in bowel sounds or hyperactive bowel sound, it may be an bowel disorder like adynamic ileus, peritonitis, or obstructive intestinal or colonic pathology. Laboratory and others are beyond the scope of our lecture. Now we turn our attention to irritable bowel syndrome. You remember, I have told you that there are some functional diseases, some functional gastrointestinal diseases. Irritable bowel syndrome is the most frequent one in this. And this is an intriguing disease. Difficult to manage. The slides are again in Turkish, but I am going to tell you in English. It is characterized by bloating, pain, abdominal pain, and there is a difficulty in defecation, or opposite, there is diarrhea. In this disease, there are two types. One is constipation dominant and the other is diarrhea dominant. But in some patients, there may be alternation between constipation and diarrhea. So for a long time, the patient may have been constipated and then he or she develops diarrhea for some time. So there are different types like constipation dominant, diarrhea dominant, and indeterminate. In indeterminate one, there may be alternating attacks of constipation and diarrhea. It is called as an diagnosis of exclusion. Diagnosis of exclusion means that there are no definitive criteria to diagnose this disease, and we can only diagnose this with excluding the other potential causes. However, recently some criteria were developed for the diagnosis of irritable bowel syndrome. For example, if there is pain which starts with bowel movements and after the pain, the feces is becoming softer. If the pain is relieved after defecation to some extent, there is bloating. 25% of the time there is insufficient defecation feeling, and more than 25% of the time there is mucus-containing diarrhea. These are the criteria may be helpful for the diagnosis of irritable bowel syndrome. It is affecting females more than males, and it is very common in all over the world. The general prevalence is between 10 to 15%. In countries like France, for example, it is the lowest, 2%. In Ireland, in Iceland, in Nigeria, the prevalence is more than 30%. So it differs from country to country, but there is no relation to socio-economic status of the country. So it doesn't change whether the country is a rich one or a poor one, the cultural level, social level, anything. There is no correlation. And in Turkey, the prevalence was estimated to be 11% according to the studies performed. We believe that in this disease, which is a complex disease, not only one system, but several systems are having some roles. Either central nervous system or autonomic nervous system of the gastrointestinal system, or both. Intestinal flora and motor function of the intestine may have a role. There may be some genetic factors modulated by occupational factors, but certainly emotional factors are having a significant place. Irritable bowel syndrome may develop after a bout of gastroenteritis. And so it seems that it may be triggered by some bacterial infections as well. And we believe that the visceral hypersensitivity is also having a role. So, for example, if there is no hypersensitivity, the same amount of case in intestine may not produce any symptom. But if the subject is hypersensitive, then he would describe pain and bloating. There are some studies suggesting that there is a relation between intestinal bacteria, microbiome, and irritable bowel syndrome. We have told you that in our somatic organism, there are 10 trillion cell and 23,000 different genetic structure, but in colon, there are 100 trillion bacteria and around 1 million different genetic structure of the bacteria. So it seems that intestinal microbiota is much more diverse than our somatic body. And we believe that there is a relation between these intestinal microbiota and the development of neurological systems. So after birth, the development of nervous system of child is highly dependent on the healthy state of this microbiota, because there is a crosstalk between microbiota and central nervous system. In these patients, despite this is not a serious disease, there is a great suffering. The patients are complaining that their condition is not taken seriously by physicians, and they cannot be treated effectively. And because there are some problems with work environment due to bowel movements, due to pain and bloating, the work performance may also be affected. And social and familial life also affected because of this disease. So there is an enormous suffering in society level, despite this is not a serious condition without any morphological findings. Actually, if somebody is involved in the management of these patients, he or she should spare more time for listening to the patient, to gather the data and to analyze them and to make a synthesis according to this. But mostly gastroenterologists are preferring to perform endoscopy, and they spare less time for listening to the patient and using their cognitive functions. That's a pity. So because of this, we are going to talk some special clinics have been developed for the management of irritable bowel syndrome. These are the symptoms: food avoidance, emotional distress, interference with the activities, social reaction, health worry, body image, sexual problems, relationship problems. So you see that at least half of the patients are very seriously affected by this condition. In the management of these patients, psychiatric consultation is important, and psychiatrists are more adept to listen to the patients for a long time. So only having the possibility to tell their symptoms without interference from the physician may also helpful for the patient. So in the management of these patients, we should advise to consult a psychiatrist or clinical psychologist. Several studies have suggested that in the patients with irritable bowel syndrome, prepubertal trauma is having a major part, prepubertal psychological trauma. And in general, in these patients, the rate of general trauma, physical punishment by anybody, sexual events, and emotional abuse is significantly more common in comparison to controls. And these can be revealed by a psychiatrist, and if the patient solves this problem and settles this problem in his or her mind, then irritable bowel syndrome may be positively affected. And you see that the emotional disturbance is very common in young population. For example, in the United States, the people who come to be soldier, so they want to serve in military service. You see there is a professional military service in the United States. 3/4 of these are rejected because of emotional instability. It is a very, very high rate. Anxiety, behavioral disturbance, and emotional instability. And you see that in the wars in the United States was involved, there were several unwanted events happening because of the psychological instability of the soldiers. So you see that even 3/4 of them have been rejected. In the remaining ones, there are still some emotional problems. So this is very common in the society. Because of this, irritable bowel syndrome is also very common as well. What is the relation to food? There is no universal rule. Some patients may be affected by something, the other may be affected by the other nutrients. So we cannot say something applicable to all the patient, and that should be individualized, and it is better managed by a dietitian. So in order to respond to the questions of the patients for the diet, then it is better to refer these patients to a dietitian. As I told you, because the management is very difficult, some specialty clinics have been evolved in recent years, especially in the United States. And in these clinics, integrated clinics. There are gastroenterologists, psychiatrists, dietitians, and alternative medicine specialists, because in some patients, methods like alternative applications like acupuncture may work for these patients. So we should not underestimate the role of alternative medicine in these patients. As a result, conclusion, irritable bowel syndrome is affecting 1 in 6 to 7 persons in the society, and it is causing great distress. Etiology is not known, but we believe that psychosocial stress is triggering the condition and worsening its course, and psychiatric consultation may be helpful for these patients. And if we manage these patients, they will be very happy like these birds. Thank you very much.